Welcome to Part 86 of Decode Healthcare with Harshal. Today, we're taking on one of the most heavily tested and complex areas of the ICD-10-CM official guidelines, Chapter 19. We're talking injuries, poisonings, and external causes. Look, if you've been following along, you already know these guidelines can sometimes feel like trying to navigate a maze in the dark. But today, we're turning the lights on. We're zeroing in strictly on Section IC19, and we are going to break down the exact, non-negotiable laws you need for coding trauma, burn staging, and that notoriously tricky chemical matrix. No fluff, just the facts you need. Let's get into it.
Here is our game plan for today. First up, we're decoding those crucial 7th character extensions. Second, we'll tackle the strict CMS sequencing rules for multiple injuries. Third, we're breaking down burn and corrosion staging. And finally, we will conquer the poisoning table matrix.
All right, Section 1, 7th character extensions. Let's define the exact phases of a patient's care.
Almost every category you encounter in Chapter 19 demands a 7th character extension. These are the universal modifiers for trauma, and they tell the payer exactly where the patient is in their treatment journey. A stands for initial encounter. But hey, don't let the word initial trick you into thinking it only means the absolute first time seeing a doctor. What it actually means is that the patient is actively receiving treatment for the condition. Think ER evaluations or emergency surgery. Next, D is for subsequent encounter. You use this when the active treatment is completely finished and the patient is moved into the routine recovery phase, like coming in to get a cast taken off or getting sutures removed. And finally, S is for sequela. This is for a direct late effect or a residual complication that pops up after the original injury has totally healed. A perfect example? A scar forming months after a severe burn.
Now this is exactly where a lot of coders get tripped up. The active treatment phase is tied to the active treatment phase, not the provider. The guidelines are crystal clear on this. Even if a patient is transferred and sees a completely new surgeon at a totally different hospital for emergency surgery on their fracture, that new surgeon still reports an A. Why? Because the treatment is still active. Conversely, if a patient goes back to their original doctor just for a routine checkup to see how a healed bone is doing, that gets a D. It's all about the phase of care, not who is in the room.
Moving right along to Section 2, multiple injuries and the CMS sequencing rules.
When a patient rolls into the facility with multiple traumatic injuries, you absolutely cannot just list the codes in any random order you feel like. The hierarchy matters immensely. The golden rule here? You must always sequence the most severe injury first. You are looking for the injury that poses the highest threat to life, function, or is the chief reason for the care. You'll code each separate injury individually unless a specific combination code exists, but there is a massive exception to this rule that you need to watch out for.
If you have a severe, deep injury and a superficial scrape at the exact same anatomic site, you code the severe injury and you drop the superficial one entirely. This rule brilliantly prevents redundant coding on your claims. Think about it. If a patient has a deep puncture wound to their right knee, and they also have some minor surface abrasions on that exact same right knee, the guidelines mandate that you completely ignore the abrasions. You only code the deep puncture wound. The same logic holds true if a primary injury results in minor damage to peripheral nerves or blood vessels. Code the main injury first, then add your secondary codes for the nerve damage.
Let's shift gears to Section 3, burn and corrosion rules. We need to talk about staging and sequencing.
Before we dive into the stages, keep a quick distinction in mind. ICD-10-CM separates burns, which are thermal injuries from heat, electricity, or radiation, from corrosions, which are chemical burns. But here's the good news. The coding guidelines for both are exactly the same. CMS requires us to classify them strictly by depth. Step 1 is first degree, which is just redness of the epidermis, or erythema. Step 2 is second degree, involving blistering and partial epidermal loss. And Step 3 is third degree. This is the deepest, involving full-thickness necrosis of the underlying tissue. Your documentation absolutely must specify this depth for every anatomic site affected.
So what happens when a patient has multiple burns? The highest degree burn always takes the #1 slot on your claim form, no exceptions. If a patient comes in with a severe third-degree burn on their hand and a milder second-degree burn on their chest wall, that third-degree hand burn is sequenced first. Furthermore, if a patient has multiple degrees of burns on the exact same anatomic site, you only assign a single code for the highest degree. Got a first and a second-degree burn on the right forearm? Just code the second degree. The lesser burn gets bundled up into the more severe one.
20%. Lock this number into your memory,
because it is the critical threshold of total body surface area for third-degree burns that legally triggers our next mandatory coding rule.
When the total body surface area of a third-degree burn hits that 20% mark, or if the documentation is just lacking and the specific burn site is totally unspecified, you are required to pull in Category T31. This uses the classic Rule of Nines calculation to classify burns based on the extent of body surface involved. This data is absolutely crucial for burn units and national mortality statistics. But remember one vital detail. Category T31 is for acute burns only. Never ever use it for sequelae or late effects of a healed burn.
Finally, we've arrived at Section 4, the poisoning table matrix. Let's decode the logic for these T-codes.
This right here is the climax of Chapter 19, the T36 through T50 chemical matrix. The table of drugs and chemicals is your starting point, but you must always verify your code in the tabular list. Why? Because the intent, whether it was accidental, intentional, an assault, or undetermined, changes everything. This three-way split matrix you're looking at is literally your ultimate cheat sheet for decoding how to sequence the T-code versus the manifestation. Let's break down each of these three very different scenarios.
Let's start with a true poisoning. The absolute most important rule here is that the T-code takes the lead in slot number 1, followed by the symptom it caused in slot 2. Poisoning happens when a medication is used improperly. Wrong drug, wrong dose, or even the wrong person taking it. For example, if a patient is prescribed 1 tablet of amoxicillin, but they accidentally take 4 tablets and develop severe nausea, that's a poisoning. You code the T-code for the poisoning first and the manifestation, the nausea, second. This category also covers provider errors, taking a non-prescribed drug with a prescribed one, or mixing any medication with alcohol.
But what if the patient did everything right? That is an adverse effect. For a therapeutic adverse effect, you completely flip the priority. You code the symptom or manifestation first, with the T-code trailing in slot 2. This means the patient followed the rules perfectly. They took the correct drug at the correct dose, exactly as prescribed by the doctor, but boom, they had an unexpected negative reaction. Using our amoxicillin example, if they take exactly 1 tablet as prescribed, but they break out in a massive rash, that's an adverse effect. The rash, which is the manifestation, is coded first, followed by the T-code for the adverse effect of the amoxicillin.
And then we have underdosing. If a patient is underdosing, you sequence the underlying medical condition they are being treated for first, the underdosing code second, and any known non-compliance code third. Underdosing simply means taking less of a medication than is prescribed, or just deciding to stop taking it entirely on their own initiative. The golden rule here: an underdosing code should never, ever be assigned as a principal or first listed code. If a patient's underlying condition relapses because they stop taking their meds, you code that relapsed medical condition right up front in slot 1. So we've successfully coded the physical trauma, we've staged the burn depths, and we've decoded the poisonings. But consider this for a second. Once you've coded the injury perfectly, how do you report the actual cause of that trauma, the how and the where it happened, to paint the full picture for the payer? Think about it. That wraps up part 86 of our explainer. Do me a huge favor and hit that subscribe button so you don't miss part 87, where we are going to tackle Chapter 20 and the incredibly strict rules for external causes of morbidity. Keep this explainer handy as your ultimate cheat sheet, and I will see you in the next one.